say thank you very much for the organizers. And I know in such cases, there's always, hidden heroes behind such organizations and tremendous amount of effort. So I really would like to say thank you for the efforts and wish all of you a very fruitful, fantastic webinar. It's really a good thing that among all these last 2 years we have been facing, putting such things put together is something we really appreciate. Thank you very much for that. Said that, I would like to give you a kind of a story about our point of view, and especially after Elaine from, if I'm pronouncing right, from France, had a really good start by describing we need further and better development with the cancer treatment. Currently, the classic treatment is either you pull together the patients and give a chemo or a radiotherapy, and which is maybe more case specific, or of course the operation. But there are many cases that we are late or it develops later on, and we're still in search of new things. And for that reason, we have been trying to identify genetic biomarkers within the urine samples for early detection of the prostate cancers. So, how do I move? Yeah. So what do we know about prostate cancer? It's actually the cancer that is growing within the prostate gland. And it's a relatively slow growing and relatively late symptom giving cancer type. In many of the patients, they, at the very beginning, they don't feel a thing, they don't have an experience. And then once they come to, it's actually a relatively advanced. So therefore, it makes you kind of start to have the feeling that you need something new to it. And when you look at for example, 2021 estimates from only for US, you can see that it's actually yearly for overall cancer, you have approximately 2 million new cancer cases and more than 500,000 cancer-related deaths, unfortunately, which again, the same estimates puts the prostate cancer is number 2 in rank. That is often as the sort of the estimation, of course, these are. And in the death rate, it's number 5, where you have the rank the prostate cancer. So with these, let me emphasize, what do we want to reach with the cancer? And we all know, everybody who works with it, and even the students, like university students by now know that the cancer is an uncontrolled cell division. It's a kind of you could say that it's a faulty of a cell cycle. And it is a polygenic changing, so it's more than one gene contributes to it, which makes it very difficult to fight with it. And of course, when you look at it only for the cell, only for the cell cycling, there's many issues that comes together, like the cell cycle control, apoptosis, which there are combination. Many genes can contribute into it. That also makes the cancer to be treated difficult. So some of the researchers, if you say the cancer researchers divided into different groups, some of them, while they are trying to find new treatments, we all have the same aim, where we want to have the cancer is a kind of manageable chronic disease, something like you have a flu or a stomach ulcer, where you have a realistic reachable targets and you can give a controlled treatments for it. How you can reach this level, like making it as a chronic manageable disease, there are several ways, and there are several research groups working on, for example, understanding the genome, the proteasome, how do they change, what we can block or target for the treatment. The more we understand the disease process, like the steps, initiation, progressions, and then the cancer happening, and then metastasis, you can target different. And of course, do you go for a mechanistic-based therapy? But in our opinion, the easiest or best approach will be using the new technologies and finding simple and early diagnosis before it comes to basically really a big problem, like the cancer just initiate it. You can have an early treatment or early diagnosis where you have a better chance that you could target the cases. So when we look at the prostate cancer specifically, we know that there's many parameters contribute to it. Age, heredity, which means that it is in the family, and especially if they have it in the first degree, relatives, and especially if it has a brother rather than the father, has a double risk. Race, obesity, inflammation, smoking, which is shown that it is actually a big problem for many of the cancer types. If the family has a hereditary breast and ovarian cancers, that means they are having higher predisposition, prostatitis, or sexually transmitted disease infections, especially repeated if they have, then there is a high risk group for the developing prostate cancer. So for this, currently you look at it, okay, what do we have in hand? What are we doing? And how well it is, the diagnosis, and what is the golden standard? And despite that, why the prostate cancer is estimated still is the number 2 cancer and ranked as number 5 in the cancer-related death. So the golden standard so far, it's the prostate-specific antigen, PSA levels, looking at them in the blood. Digital rectal examination, which is a bit of a discomfort for the patients and often explains why the patient does not come early to the clinics. And of course, the prostate biopsy, especially transrectal ultrasound-guided prostate biopsies. And last 2, you can hear that it's not 100% maybe invasive, but it's discomfort giving, and often it explains why the patient does not come directly. So it makes us that we are down to, in reality, 1 screening test, which is a PSA. And as everything, PSA also has advantage and disadvantages. One of the advantages that so far we believe that it's a highly organ specific, so it tells about the changings on the prostate. It is good for early detection, and it's sort of easy, cheap, because you can just draw a blood, 5 millimeter blood, and then look for the levels of the PSA. The biggest disadvantage, unfortunately, it's not a tumor specificity, which means that when there's a benign prognostic hyperplasia, prostatitis, and so forth, it increases again. And it's been believed that often that is the PSA level under the 4 nanogram per milliliter is kind of accepted as a normal. Between 4 to 10 is believed to be a borderline, but requires a follow-up. And those that bigger than 10 is actually, and only 50% of them shows prostate cancer. So you can hear that the specificity already puts a question mark. And then when you look at it, for example, from the database from the UCSC, which is the University of California, Santa Cruz, profile picture for PSA versus the KLK3, which is KLK is a kallikrein related peptides free. It's related to a group that serum proteases. You could see here that the prostate has, yes, for the PSA, high expression. Very surprisingly, the bladder has even higher expression, which also supports our suspicions about that the PSA, it's not really a tissue specific or organ specific. You can see the bladder is also, which also makes up that when we are trying to test it in urine, we should be very careful about it. So it isn't as we have been believed so far that it's a tissue specific. So then it brings us to a question, okay, what can we do to increase the diagnostic precision for the, precision for the PSA testing? Because that's the only biomarker so far we have that the patient feels comfortable, and you need to increase it. So within the last decades, last 10 years, prostate cancer antigen free has been started to use, besides the transmembrane protease serine free has been started to use both in urine and blood, and then also tissue biopsies. There has been some digital and database evaluation in silico for like the 4K scoring, me prostate scoring, prostate health index, and so forth. And unfortunately, none of them is sufficient enough. So we still have need for a new therapies, new diagnostic markers, which we believe that the key is underlying in the finding new biomarkers that will allow us to do an early diagnosis, biomarkers that will allow us to have the risk prediction. And again, developing new biomarker-based tests will allow us both same time. So with that question, we started to look at what genes that has been so far named that they are related to a prostate cancer. You can see from BRCA1 and 2, CHEK2, which is well known in the cancer process, homeobox genes are named pretty much. These HOX genes there are 39 clusters. They've been clustered in 4 groups as 4 HOX families. And one of them, the biggest one, is the HOXP13. And these has been identified with the genetic linkage studies. And there has been like 5 different very common variants that has been shown that they are active or they have been related to prostate cancers. And then when you look at the human gene mutation database for the professionals, you can see the HOXP13 is there. And that made us, if we start out trying to identify a biomarker, they should be a good candidate to start out to, first of all, test that our idea is working. And the secondly, to test that we could actually detect prostate cells within urine. When you look at the literature, what has been done from 2003 till now, there has been a couple of studies, but the problem is that more or less there are one study for each mutation. There isn't many of them, which makes us that it's not strong. But it's said that combining PSA with the urine transmembrane prostate serine 2, actually you could see that it improved the cancer prediction, but prediction only, up to 90% specificity, 80% of sensitivity. So it tells that, including more biomarkers is a good algorithm to combine these, and you can have a better diagnosis. So when you look at it, there has been in time around 2014, 16, 19, more and more came. You said that again, there are only few, but they have been, when you look at it, first of all, they have been used for together with PSA to identify whom to biopsy, then whom to rebiopsy, whom to treat, whom to not to treat. So all these made us that believe, we are in the right track. So first you start to look at the PSA levels. The current application is like that. Then you use the digital rectal examination to find if there's any lump or not. If there is one, they use this which is a transrectal ultrasound guided biopsy, and then send the samples to biological analysis, pathological analysis, do the analysis based on the Gleason grading and staging. And if there is a positiveness, then they put the diagnosis of a prostate cancer. Yet, with these so-called very detailed approach, we still lose the approximately 30% of the tumors are missed during the sampling. Either the biopsy is not get from the right point, or the PSA is benign and then misleading, or elevated PSA level is shows a negative initial biopsy, so it actually delays the people go for a rebiopsying later and so on. So you are actually missing most of the approximately 30% of the positive biopsies, and the treatment becomes late for those patients. So with these basic information, we decided that we could raise a couple of questions that we wanted to address. One was can we catch the prostate cells within the urine samples, because before that there has been 1 or 2 studies suggesting that yes, you can. Some said no, it's not sufficient. So we wanted to raise the same question: can we catch it, and when can we use them for identification of the cancer, use it as a diagnostic biomarker, and they are sufficient enough for information. So with that, basically it brings us to our initial question. It will allow that early diagnostic information if you were capable of catching the prostate cells in the urine samples. Of course, we choose only one gene as a start to proof of principle that we could detect all somatic and hereditary mutations within these samples. And then with that, it will allow us to find who is eligible for the prostate biopsy and who should, what is the risk assessment and who should be getting treatment or not. So we made our own study design. Basically, between from January to May, for 5 months, we had all the patients who has been to the urology clinic and had elevated PSA levels and abnormal digital rectal examination results. Then they referred to the prostate biopsies. Before biopsy, we collect up to 30 milliliter urine samples from these people. And then from those urine samples, immediately within half an hour, we make the mRNA isolation and then cDNA synthesis. Because we had a targeted gene, HOXB13 gene, we made a Sanger sequencing for those samples, use the results coming out from the Sanger sequencing to compare in predicting the risk scores in silico. Currently, as you all know, that there is several common in silico databases that used for this, like Polypen, Swift, mutation taster, CAT. We use all those tools and compare their cutoff values to get a prediction. And then we, as an endpoint, we compare our results to pathogenicity coming, like the biopsy results coming from the pathology department. So, to basically our surprise, there has been a couple of answers. One, that we identified 9 new mutations that hasn't been published before. And we could see all these 9 mutations. Mind you that we only had eligible for this test within 5 months, 13 patients. 3 of them later on, they didn't want to be involved in the study, so we couldn't use their urine sample. And one of their, out of left 10, the sample during the process was not good quality, so we couldn't involve. So we had like 10 patient sample in all, and then we detect 9 new germline variants. Surprising part was that we did not observe any of the previously identified HOXB13 variants, but we identified some new variants that was basically either heterogeneous or homogeneous, or heterogenic or homogenic, and they were basically maybe benign or malignant. So, of course, once we have it, we had to have internal controls. One of the internal controls we used was the beta-actin as an expression control. And the other control we used was the HP gene, HPG1, which is a specific for only prostate cells, which allow us that all the samples that we collected, we could refer them, yes, these were the prostate cells, and you can detect, as the first question, in the urine sample enough sufficient amount of prostate cells that you can do a Sanger, for example. And when we look at the electrograms, we could see that, yes, we could, in patient samples, we could see different heterozygosity mutations like these, or you could also have this homozygote mutations. So when we go through all the samples, and then we try to use the pathogenicity prediction for these HOX13 variants that we have found, and go through all the well-known classical databases, polyphen, Provan, CIPS, mutation taster, CAT scores, and so on, we could see that 2 of them was benign for some of them. For one, it was a neutral. For example, in this case, the polyphen 2 says it was a benign. Then Provan said it was neutral. SWIP said tolerated, still put it, it's not that, for example, maybe malignant. And when you look at the mutation tester, it was saying that disease causing had a score of like 76. So we went further, we put them all together and then try to compare which one means that it was deleterious or probably damaging or benign. And when you look at it, 5 of them turn out to match with the basically clinical or biopsy results. When you look at the biopsy results, you could see 5 was matching with the malignancy. So our biomarkers was correct, even though they were not previously published, but it matched with the our prediction. Then we tried to put them to use clinical final diagnosis, which means that it's not only the biopsy, it's not only the genetic testing, but also the patient's clinical presentation and what the doctor has decided in the end. You could see all, basically 9 of them ended up either having the benign prostatic growth, or some of them had the these matching malignancies together with it. And then you could see that the prostate cancers that has been translutral resections, which also called or treated as a prostate cancer. You had the prostate cancer radiotherapy. You had those that was pretty much going for directly just operated and not doing anything. But in the end, we could easily say that, yes, we had a sufficient amount of prostate cells within the urine samples. That was first outcome. The second, we could call our approach was as a non-invasive screening tool, and it can be used for identification and diagnostic biomarkers, and which was cost-effective, promising, reliable, and easy to perform. You could do it in every laboratory and you didn't do anything specialized. And then these approach, we found deleterious, probably damaging and benign mutations for all patients. We accepted patient number 9. And then we could use all these known databases and compare all the cutoff values. And you could see that, yes, for the most of them, those that we define as a deleterious or probably damaging was in match compared to biopsy results and the final outcome. So they were enough to say, yes, we could early diagnose the prostate cancers. So these results allow us to say, for the first time, we actually were find out an applicable, sufficient approach to select eligible cases for prostate biopsies. We also capable of finding known and unknown mutations, and this helped to make a patient-oriented risk assessment. Then you could ask, but you did not find anything that known these deleterious prostate cancer mutation that has been previously published. We have an explanation for that. Of course, one of the explanation you could say that is the geographic heterogeneity and ethnicity, but I strongly believe it's probably the technology we use, because we focused specifically one gene and a well-known mutations. But if you are using Sanger versus, for example, next generation sequencing, I'm sure you could get more specific and larger investigation where you could see all the possible mutations and it would be more informative. And of course, you could see that we had very small cohort. If currently we are trying to enlarge the study, basically we have a bigger group now and we are trying to do it with NGS as an ongoing project to see what else we can add up on it. So overall, I would like to say as a take-home message should be that even though we believe we use the biomarker research for many things, but we are still at the beginning of it. We still have lots of possibilities that we can combine. And probably these biomarker-based therapies will make more progress to improve our outcomes for the cancer treatment. And I personally believe that the biomarker-based diagnosis and the combinatorial therapy, it will be the way to go from now on to get a better success in combination with basically the radiotherapy. And this bit of the studies it was done by one of my PhD students, Eyüp Kavalcı, and it's been published, and where we actually get a well acceptance, where we had this novel non-invasive screening tool for the in-depth selections. For this, I think I'll stop here. And if there's any questions, I would be happy to address the questions and the comments. Thank you very much for your attention.
Thank you so much, Dr. Nedime, for your wonderful presentation. I really hope the diagnosis and treatment for biomarkers will go way ahead, and so your cohort studies might get a very better results for the betterment of society. I'm looking forward to your research to move forward.
Yes, me too. I'm really hopeful about this ongoing part with the NGN. So hopefully we will get better and easier approach. Thank you. I really appreciate it.
Thank you. So the panel is open for the discussion. If there is any kind of doubts, you can please ask Dr. Nedime.
Of course, if you have any questions later on, you are very welcome to mail. I think you will have all our mail addresses too.
So if there is any doubts later on for anyone, if you want to contact any other doctors, please do mail us. We will be giving you all details about our speakers, so you can contact them later.